Hi, welcome to this clinic conversation of the week, where we discuss groundbreaking research with our patients in the clinic. Today, I'll be discussing a recently published clinical trial in the New England Journal of Medicine that looked at two drugs, teclistamab and talquetamab, for relapsed or refractory multiple myeloma. The goal of this series is to really discuss some of the data and trials with patients as if they were our own in the clinic and we were talking to them and they were asking us about the data and what the research shows. In this episode, I'll be talking about the potential of this novel dual targeting approach for multiple myeloma.
Multiple myeloma is a form of cancer that's really challenged oncologists in recent years and decades, especially in its relapsed or refractory form when it comes back even stronger than before. And I'd like to discuss the promising results of a phase 1/2, meaning an early phase clinical trial that combines two groundbreaking bispecific antibodies, which are called Talquetamab and Teclistimab. This combination actually represents a really novel approach for treating myeloma, especially for patients who have exhausted traditional treatment options such as drugs like proteasome inhibitors like bortezomib or immunomodulators like lenalidomide, and also anti-CD38 antibody treatments such as daratumumab. And so, in terms of understanding the clinical trial, it actually uses a dual targeting approach. So, there's two drugs that I mentioned. One is called teclistamab, and the other one's called talquetamab. So teclistamab targets a B cell maturation antigen, or called BCMA, which is a receptor, and it's actually the only bispecific drug that's approved that targets BCMA, and it has a 60% response rate from a previous trial called Majestic One. And the other drug that I mentioned, talquetamab, targets something a little bit longer. It's called the G protein coupled receptor family C group 5 member D, or in short, GPRC5D, which had a 70% response rate in the Monumental One trial. And so both antibodies are basically redirecting your immune cells, your T cells, through something called CD3 engagement, and basically helps to create a two-pronged attack against myeloma cells. And this dual antigen treatment is sort of thought to enhance the potency of the treatment and also to help prevent resistance, i.e., preventing the cancer cell from becoming really smart to then having an even stronger form of the cancer. And so the study basically enrolled 94 patients who had relapsed or refractory myeloma, and 44 of the patients in this trial received the recommended phase 2 regimen of the talquetamab at 0.8 milligrams per kilograms, or teclistamab at 3 milligrams per kilogram every other week. And the results were pretty impressive. What we saw were that there was 80% response rate in patients who had the recommended dosing, and we actually saw 92% at the recommended phase 2 regimen among patients we could evaluate for disease. The other nice thing about the results is that for patients who had myeloma outside the bone marrow and in their blood, which we call extramedullary disease, there was 83% response. Even in this very aggressive form of myeloma, we saw patients with really good response. And over half of patients had complete response, meaning that when we did scans imaging, they wouldn't be able to find any evidence of disease, and a 33% complete response for patients who had that more aggressive extramedullary disease that I talked about before. The other really nice thing is that for patients who did have a response, the chance of maintaining that response at 18 months was 86% with the recommended regimen. So when thinking about these drugs and these bispecifics in the clinic, it's really important to sort of balance the safety of these drugs with the efficacy as well. And the most common adverse side effects that we see with bispecifics are similar to other kinds of therapies called CAR T that you might have heard of before. And it's really the cytokine release syndrome, which is sort of like an inflammatory reaction that feels like a viral infection. So it can have things like fever at its best, and at its worst can lead to drops in blood pressure, requiring oxygen, and making people feel really sick. So we saw really high grades of CRS in many of these patients, and also a lot of patients, over half of them, had some form of infection as well, and those could also have been severe at some points. There were a handful of deaths in the study, which were generally from infection. And the one caveat that I will mention is that in myeloma, you can have patients who have low immune cells or low antibodies, and so there are different ways for targeting that, but only half the patients got IVIG, which is a form of antibody treatment to help prevent infection. So there are some caveats to some of the severe side effects that I mentioned earlier, and there are some other side effects that these bispecifics have. Talquetamab can lead to things like some like dry mouth, skin changes, so that can lead to weight loss. And then teclistamab can also cause infections as well, and can cause some motor and sensory deficits. So like some forms of neuropathy, basically. So just thinking about practically implementing these therapies, it's really important to keep in mind that with all the risks of side effects, careful monitoring is really important, especially when patients start this treatment. Most patients on the trial had to have some kind of treatment modification, whether that was delaying treatment for some period of time or there was reducing the dose. And so that makes it even more important to have vigilant management, having close patient follow-up, ensuring good caregiver support, those sorts of things. So while the results of this study are very promising, there are several questions that remain. We need to better understand how this combination fits into the overall landscape of myeloma therapy, especially in relation to the CAR T cell therapy and other emerging treatments. Also, the role of looking at different bridging treatments or treatments while you wait to get CAR T for people who are eligible for that. And also, I think the high infection rate warrants more investigation into how we can do other kinds of prophylactic strategies to help prevent infections in this patient group. So now, after decades of having very limited options for treating myeloma, especially for those who are very heavily pretreated and have cancer cells that have seen all sorts of drugs and that are highly resistant, this combination approach is really a huge advance in the field. It's an off-the-shelf, availability drug, which means that it can be, manufactured, unlike CAR T, which you have to get apheresed and have to get processed, and has to be, processed specifically for the patient. And I think, in addition to the being off the shelf, the fact that it has a really good durability makes it an important addition to our therapeutic arsenal for myeloma doctors. But we have to be careful about the side effects and patient management and follow up. Thanks for listening.